Abney, and the
That's
rest of the
okay.
committee.
Want to make sure your red light is on so we can hear you loud and clear.
Can you hear me now?
You're on.
Okay. All right, Chairman Abney and the rest of the committee, thanks so much for the opportunity to speak. My name's Camille Williams. I am representing Rhode Island Midwives, the Rhode Island affiliate of the American College of Nurse-Midwives, and we are the professional association representing certified nurse midwives as well as certified midwives in the U.S. Nurse midwives and certified midwives are primary health care providers with an emphasis on prenatal, labor and delivery, including delivering babies, and postpartum care, and well woman GYN care. Most of the midwives that the group that I represent, most of us practice in the hospital setting. A few of us practice in the home setting. And ACNM supports common sense policy solutions that ensure women, individuals, and families guaranteed health coverage and access to the full range of health services that will benefit them. Doula support is somewhat of a unique healthcare service in the sense that most healthcare interventions involve some balance of benefit versus risk. Doula support during labor and birth is a service that's consistently shown to improve health outcomes for mothers and newborns with zero risks and no side effects. The data is very, very clear and abundant. There are countless studies showing the benefits of continuous labor support. I'll just mention a 2012 Cochrane review of 22 clinical trials in 17 different countries showing that continuous one-on-one labor support improves outcomes, which include, as has been mentioned, increased rates of spontaneous vaginal birth, shorter labors, which every woman wants, decreased rates of C-section, instrumental vaginal birth, meaning forceps and vacuum-assisted deliveries, that's reduced, decreased use of pain medication and epidural anesthesia, fewer low 5-minute APGAR scores, which is the measure of newborn well-being immediately after birth, and also fewer negative feelings about the childbirth experience, which impacts postpartum mental health. There is also evidence, as has been mentioned, that it results in lower rates of postpartum depression, preterm birth, and these improved outcomes are achieved with no evidence of harm or risk. Additionally, and of particular interest probably to this committee, decreased rates of medical interventions during birth translates to lower healthcare costs. There was a 2016 study modeling the cost effectiveness of Medicaid coverage for doula services, and that found an average cost savings of $976 per birth. And I did link, this has been emailed to you all, and that cost analysis is linked in there if you want to look at it. And as Rep. Ranglin-Vassell mentioned, that cost savings is largely due to lower rates of preterm birth and cesarean section with doula support. What we have now is that despite the well-documented health and cost benefits of the continuous support that doulas provide, the lack of insurance coverage means that doula support in Rhode Island is essentially a boutique service that is accessible only to people who have the financial means to pay many hundreds of dollars out of pocket. And this creates inequity, and it means that doula care is inaccessible, arguably, to those who need it the most. Nationwide, we're facing an alarming rise in the maternal mortality rate. You've been hearing a lot about that with widening racial disparity in those rates. Access to doula support has the potential to improve these disparities. In addition to my role with ACNM and in clinical practice, I also sit on the Disparities in Infant Mortality Task Force with the Health Department. And in our meetings, there's been a lot of enthusiasm about this bill and its potential to move the needle on racial disparities in maternal child health. Also, we know from conversations with local doulas who are women of color, and many of them feel compelled to work for less money, or in some cases no money at all, in order to serve women in their own communities who face additional health risks. And this is unfair and unsustainable to that workforce. Doula work is very hard work, both physically and emotionally. It involves long hours, being on call 24 hours a day for weeks at a time, if not continuously. And doulas who want to provide culturally competent care to women in their own communities who are facing additional health risks due to racism and generational poverty should be able to do that while earning a decent living for their important work. And just one last point, as midwives, we know not just from data, but from direct experience what a doula can bring to a woman's birth experience. Hands-on, one-on-one labor support is very powerful, both for the woman and for her partner, who, as much as they provide loving support, do not always know what to do, and usually, in fact, do not know what to do. So the doula provides support for the partner as well. We provide, as midwives, we provide a great deal of this type of labor support ourselves, as do labor and delivery nurses, but we also have clinical responsibilities, and we often have more than one laboring woman to care for at the same time. So the labor support we are able to provide is no replacement for one-on-one non-clinical doula support, and we very much want doulas as part of the care team. And in our clinical practice, when we're educating our patients, we face a dilemma when we are educating them about their birth options and preferences, because we can't make assumptions about who can and cannot afford it. But when we present this to them, then many of them are in a position of now knowing about this wonderful service that could be of great benefit to them, but they don't have any financial access to it. So we urge you to vote this bill out of committee and onto the floor for a full vote on behalf of women and newborns and families in Rhode Island. Thank you.